Welcome to this edition of Prime News. I'm Dr. Janice Galleshaw, and I'm thrilled to be joined today by Dr. Rob Coleman from the University of Sheffield in Sheffield, UK. We're here at the 37th Annual San Antonio Breast Cancer Symposium and thought we would touch on a couple of the interesting abstracts that have been presented here. Rob, thank you so much for joining us today.
Pleasure, Jan.
I thought maybe we could start with Martine Picard's presentation that was focusing on the NEOALTTO trial and looking at the correlation between pathologic complete response and event-free survival and overall survival. I think she did a beautiful job in that presentation, and if you can kind of share what the messages were as we walked out, we'd appreciate that.
Yeah, so I mean the NEOALTTO study is one of two really landmark trials that have shown that dual blockade of HER2 signaling in the neoadjuvant setting improves pathological complete remission rate. And that data has been known for a year or two and led to the approval of dual blockade. But what Martine was doing today was taking it one step further and showing that those patients that achieved a pathological complete remission had a better outcome. And that would infer, therefore, that one would expect the dual blockade treated patients to outperform single HER2 antagonism. So path-CR rates were about double with dual blockade, and those patients had a better event-free survival than patients who failed to achieve path-CR.
And the design of the trial, basically, we had one arm where they received the trastuzumab plus paclitaxel. Second arm was lapatinib plus paclitaxel, and the third arm was all three.
That's right. So, of course, paclitaxel trastuzumab is the standard of care, or has been the standard of care, and the two test arms of just lapatinib or the two together. So I think, we do have a new standard for neoadjuvant therapy, and that is chemotherapy plus dual blockade. Whether you do that with lapatinib as the second agent or pertuzumab is for discussion. There are some difficulties with lapatinib in terms of tolerability.
Yes, she kind of pointed out the difference in adverse events by treatment arm, and clearly the two arms where lapatinib was part of the regimen had a higher incidence of some of the specific adverse events.
That's right, particularly diarrhea. Mm-hmm. But in my experience, if you're going to get diarrhea, it happens pretty early on. So if you can get through the first cycle or two, then you're probably going to be okay. So you get quite an early signal whether patients are going to tolerate this.
And it's a drug that lends itself to dose modification too. You can alter the dose of the drug pretty readily and sometimes overcome the diarrhea, don't you think?
That's right, it's very dose dependent.
Mm-hmm.
So coming down 20% can often transform the quality of life for the patient and probably doesn't impact too much on efficacy.
Well, so the take-home messaging here is that do we have a new standard perhaps in how we can look to approve drugs that show promise by doing it in a preoperative setting and in smaller sized trials? Do you think we're changing kind of the way we approach this?
I think we are. I think the evidence is pretty overwhelming that path-CR predicts for better outcome, mm-hmm. and this was just another example of that. I'm not sure we'll get rid of adjuvant studies altogether, but hopefully they can come along as almost sort of phase 4 evaluations, as confirmatory trials rather than the prerequisite for approval.
That would be great. That would be great. Not all patients necessarily are referred in a preoperative setting, so we're oftentimes treating those patients in the adjuvant setting, and it's nice to have that follow-up information as well.
Yes.
Well, next, I would love for you to tell us about your presentation. You were looking at the effects of bisphosphonates on recurrence and cause-specific mortality in a very large meta-analysis, and I would love for you to kind of elaborate on the challenges because of the sheer size and the individualized analysis that you did.
Yeah, so we've been working with the Oxford Early Breast Cancer Trials Group, who have a lot of experience of doing these meta-analyses. And what we wanted to do was try and just sort out once and for all whether these drugs have a role in the adjuvant setting. So we've collected all of the individual patient data that we can possibly trace on a global scale, which means that we've had data from approximately 18,000 women who've taken part in randomized trials of bisphosphonate versus not. All those individual data points are checked and cleaned, and then we're in a position to run outcome analyses. Our main outcome, of course, is disease recurrence, but then we've looked at survival and patterns of recurrence, particularly bone recurrence, because these are bone drugs.
Mm-hmm.
And I think we feel that we have defined a new standard of care for postmenopausal women. These drugs reduce recurrence in postmenopausal women, particularly bone recurrence. Bone disease is reduced by about, more than a third,
Right.
highly statistically significant. And that's translating into a survival advantage, approximately 1 in 6 fewer deaths. So that's an incremental benefit that's similar to going from, adding a taxane, or it's more than adding an aromatase inhibitor.
Absolutely.
So and at low cost, both financially and in terms of side effects for the patient. So I think it's been a very worthwhile endeavor.
Well, and I think you also touched on even younger women, as long as their estrogen was being suppressed, they achieve the same benefit?
They do, that's right. It seems to be what the circulating estrogen and reproductive hormone levels are. So if you're a young woman and have ovarian suppression therapy, or indeed a oophorectomy, then you could be considered for this treatment. Where I think we would caution against bisphosphonate use is a woman who's still menstruating and having normal reproductive function.
Because there wasn't a benefit identified in that setting.
We couldn't see any benefit. We couldn't see any harm,
Mm-hmm.
and some trials have suggested there might even be harm in that setting.
Mm-hmm.
I think we can reassure people that it's not harmful, but it's just not helpful. And so, we wouldn't recommend in premenopausal women. But of course, postmenopausal women are the vast majority of breast cancer sufferers.
Yeah, definitely. Well, that's great. And I know it was fairly tedious work for you, but congratulations on a great trial.
Yeah, well, actually, it's the team in Oxford who do all the tedious work.
Congratulations to you and the team. Well, thanks so much again for joining us. We're going to wrap it up now, and thank you for joining us as well for the news that you can use.